She's a doctor.
Hi, I'm Dr. Dovec, and she's a dietitian.
Hey, I'm Hannah Schuyler, and together we are
the Doctor Dietitian Collab.
Hello.
Hello. Wow. Welcome to part 1 of our medical weight loss series.
This is so exciting. This is going to be a 4-part series talking all about medical weight loss. And when we say medical weight loss, what we're talking about is using medications rather than or alongside surgery.
Exactly. We're going to talk a lot. We're going to get down and dirty with all the details after I put that little teaser reel on my Instagram with, whoa, here's this complicated pathophysiology of all the places that the injectable medications work. I got, there was so many, I'd say about 50 at least, patients who DM me like, I need to learn more. And I'm like, wait till our pod.
We got you. So today, we are just going to get started. And don't worry, all that fun stuff will be coming up. We're going to cover absolutely everything.
Yeah. And we want to make sure that, we are going to be having a ton of episode guides with these. This is, we want to break it down. We want to simplify it. We don't want it to be confusing. We want to make sure that if you would benefit from this treatment, we want you to go for it. So make sure that you go to drxdietitian.com, subscribe to our blog, our episode guides, and you're going to learn pretty much all that there is to know about
everything you could want to know and probably more.
Now, right now, let's acknowledge we are in the midst of the holiday season here. It's December.
Christmas.
Oh my gosh. Your first Christmas as a married woman. How are you doing with that?
Oh, it's good. I don't know what I'm buying my husband for Christmas yet, but sorry, babe. We'll figure something out.
Yeah, same with mine. I mean, I just feel like if he wants it, he gets it. And we just live this charmed little life over here.
Well,
so
we're a little in the same vein.
No, you just got married. I mean, what else could he want? He got you. I mean, seriously.
Right?
I mean, for real.
Literally the best gift you could ever get.
I think it is. Oh, my goodness. So some of you out there are in the midst of the holiday seasons and you're also just at parties and you're just feeling maybe not yourself this year, or you're just feeling a little uncomfortable. And so I want to just dive right into who qualifies for weight loss medications. And, maybe you are somebody that did not have surgery and you really don't want it either. So we're going to talk about BMI qualifications. BMI, again, is body mass index. And so if you don't know what your BMI is, just Google it. Just Google BMI calculator. And you can put in your height and your weight. Boom, there it is. So those who qualify are a BMI or body mass index of 27 to 29.9 with weight-related issues. So diabetes is a big one, sleep apnea, high blood pressure, high cholesterol. Now, if your BMI is over 30, you qualify for the medications based on your BMI alone.
Right. So that's kind of a good thing to note, is because for surgery, it's 35 and up is the start of that. So you might also fall into that maybe 30 to 35 category where you don't quite qualify for surgery either. And these could be a really good, kind of intervention to even prevent you from getting to needing surgery.
Exactly. So the 3 big categories that I see that qualify for medications are, number 1, if your BMI qualifies, so you're from 27 to 34.9, but your BMI does not qualify for surgery, but you qualify for medications, go for medications. Number 2, some of you out there actually do qualify for surgery. Your BMI is over 35, but you're maybe not quite ready yet. You're like, I gotta try this first. Surgery's not for me. I just don't know. And that's fine. Maybe you're in that phase. That's perfectly acceptable. Go for the medications as a first-line treatment. And then, of course, the final one is those of you who have had surgery and maybe you're stuck on a plateau, or maybe you have gained weight. Now, one thing that I am so excited for the future to really start to provide our patients is kind of think about like a kid's growth curve. Think about like the trajectory for where you should be on that line. Like your child should be at, okay, here's the 50th percentile for your height, 50th percentile for your weight. You can see where your child or even yourself on these things falls on that. So what I think is something that's really powerful, and I think the future is absolutely dictating this, is having these sorts of trajectories for our post-op weight loss patients. So of course, it is this comparison. If you start off with weighing 200 pounds and your BMI is 35, you're obviously a little different than somebody who starts off with a BMI of 70 who's 500 pounds.
Right.
And we have the whole gamut, and we have support groups, and we have patients who are in there and they're saying, well, I mean, they lost 20 pounds in the first week, but I only lost 2. Like, it is a proportion. It's all your perspective where you would fall.
Right. And where you've been and your body type and all of those kinds of things, and it's a percentage, though, if you really look at it. 2% or 2 pounds is 1% of one person, and it's 0.1%.
Look at you, math expert. Yes, I mean, come on.
Whatever.
No, but you're right on it. But no,
yeah.
I mean, it's true. That's like, and for 2% of 500 pounds, we're looking at 10 pounds lost. So it's a huge, huge difference.
You did better math than I did.
I hope that was the right math, because now I'm like a little bit like, but you get the hint.
All numbers are approximate in this show.
Yes, exactly. Disclaimers. Oh my gosh. So that's really, that's what I want to show, is that, okay, here's your trajectory. You've lost 5 pounds. Nope, you're right on track. Actually, you're ahead of schedule, or you are a little bit low. And it's about this real-time intervention and intervening even earlier than you would had you maybe, oh my gosh, I've been stuck. Is this the way it should be? Or is this something that maybe we need to add a weight loss medication as a post-op patient in the very early post-op period, actually?
Yeah. And I think it's interesting, too, when you look at like the whole trajectory, like you're saying, like, yes, it's earlier intervention, but it's also looking at if somebody longer term. I did a study on this, and of course I did last year, that was like, okay, we have, Samantha, and she started at this weight, and then in college, this was her weight, and then she gained weight, and then she lost weight, and then she had children, and this is that and the other. And you just see her whole weight history as a trajectory as well. And you see where she's come from, where she's been, and then surgery intervention. And then you look, okay, surgery was successful for a period of time, and then weight loss, medication intervention. And so just really seeing like that patient as a whole picture and a whole person, and life gets, what happened, where were these points?
I am obsessed with that whole concept. And I encourage all of you out there to actually do what Hannah just described. You need to really write down your life, because we always ask our patients, so when did you start to struggle with your weight? Some will crack a joke, as they will, even though they're hurting on the inside, and say, I think I came out of the womb, I was a big baby. I feel like I have always struggled with my weight. I don't remember a time when I didn't. We have some patients who are like, I was so tiny, I was so thin, and then I had a baby, or I went through menopause, or I had a really horrific thing happen to me, emotional experience, whatever, and then I gained weight. And it's just been this like before and after that. So I would encourage you all to write sort of like these major milestones in your life. Okay, you just got married, so you're looking good, you lost weight, and then I had a kid, and then I gained some weight, and then I lost again. I started phentermine, and then you'll see these sort of these patterns. And I love that as part of, like, when we're doing an evaluation of a patient for the first time in initial consultation, I love the idea of like kind of plotting out that kind of that life for me to see, and for me to understand, and for you as the dietitian to really come in and understand too.
Yeah, because then we look at things like if you were leaner, say like in high school, early college age, like that might be a more realistic place for you to aim for, versus somebody who's struggled since adolescence and may not get to some of those lower weights because it's just never been how their body has been set, or it might be more of a challenge. And so just knowing that history, I think, can really guide treatment and guide intervention as well, to know when should we be stepping in? Should we be aiming for something a little bit lower for a certain person?
Exactly. And I think that it helps with all the frustrations that can be associated with it. Like you just said, if you have struggled since you were a little kid, and this is, strong genetics and just strong environmental factors and all of those things, then sometimes like the medication, it might be like, all right, listen, I'm going to give you you have tried your best. Like, I'm giving you a pass that maybe surgery, let's intervene with surgery even earlier than, doing this medical weight loss. And, oh gosh, I've only lost a couple of pounds. And we're going to talk a lot about the science in a not boring way that just kind of describes why sometimes these medications are much more effective for certain body types. And not only that, this is a great spoiler alert, is that these medications, especially the most popular ones, which will be on part 3 of our medical weight loss series, which is going to be on the injectables, those GLP GLP-1 agonists, guess what, you guys? After surgery, your GLP-1 levels are going to go up. And that means that those medications are actually going to be even more effective after surgery than they were before surgery. So, and even the pills and all the ones we're going to talk about. So if you're like, oh my God, I mean, now I have to go back to the pills. Well, they never work. So why would I think they're going to work now? That's why I had surgery. I mean, duh. Well, guess what? It is a little bit different this time around. So I would encourage you to give it another chance if you're kind of stuck on that plateau or again, gaining some weight back.
Yeah.
So we're going to intervene early. All right. So I want to talk a little bit about all of, the different kind of the idea of the comprehensive approach to this. So I think just having surgery on its own ain't ever going to work.
Right.
Just taking a medication, a pill or injectable, it's not going to work. You need to, and we're going to spend part 4 of this a lot on your expertise on the medical nutritional therapy, on a true weight management program, lifestyle, diet, exercise, and also behavioral therapy as part of this whole thing. So we are not telling you guys by any means, oh, and by the way, we'll have these disclaimers. This is not a substitution for medical advice. If you're having a true medical emergency, call 911, of course, or seek your own healthcare provider to give you the care that they would in prescribing these medications and all of that sort of thing. But I really think that we want to make sure that we're very adamant that this is not something that can be done in isolation alone.
Right. Well, it's similar to the surgery. We always say this is a tool and it works if you use it correctly. I can hand you a wrench, but if you just hold it and don't wrench something.
Twerk it? Is it twerking or is that something else?
Yes, if you don't twerk your wrench, it's not going to do anything. It's just a wrench, until you actually use it.
Exactly.
Maybe a hammer. I know how to use a hammer. I do know how to use a wrench. I want to clarify I know how to use that, but I don't know the vocabulary for it apparently.
Well, I'll tell you what, I would never use a hammer because the next thing you know, I just crush my hands and there it all goes.
She's going to break her fingernail, guys.
Oh, well, there's that too. But yes, so I believe in these medications so much that in 2020, I took a trip to Vail, Colorado. And, this is a random thing.
What a sacrifice you made to go to Vail.
Well, I went to Vail in 2019. Actually, let me back up. And it was in August. I went there. I don't ski. No way.
I've seen you dance. I don't want to see you ski.
No, you don't. I sweated through a true winter coat when I try to ski. I did. And I know this how? It's waterproof. It wasn't. It was that amount of sweat. I almost passed out. My sympathetics, which we're going to talk about the sympathetic nervous system, my friends. Ooh, get ready.
We're tying it all back in.
We're tying it in. That has to do with ephedrine. But anyway, my sympathetics or my fight or flight was in such an overdrive that I was just freaking out. So I tried skiing once. This was not this time. This time was in the summertime in Vail, which was a very, very beautiful thing. You go up the mountains and then you jump on trampolines and stuff like that. Okay, we can handle this.
That sounds great.
But anyway, the whole point of this was I had a spiritual awakening when I was there that I realized, on this family vacation, I'm I need to get into the weight loss and medication space because I have heard many patients who come back and they feel like failures or they just are oh, what do you think about the meds? And I'm going to just put it out there. I was always super ignorant. I was you don't want to do that. So there might be some of your primary care physicians, your providers, your gynecologists, your endocrinologists that are no, those things they're hacks. They're terrible. And I decided before I could say something, again, so ignorant, I need to absolutely learn about it. And that's why I did take the American Board of Obesity Medicine examination. So I'm a diplomate of that. I passed the exam and I am now a bariatrician in addition to being a bariatric surgeon.
I think you bring up such an interesting point because, these medications can be prescribed by a primary care doctor or endocrinologist, all of those things. And some of them will do it. But I do think that they're for so long, and especially with the injectables being so new, a lot of what we were relying on was the pills and things like that. And people were ignorant of them or what they do and they didn't want to do it. Or it's you have somebody who has some extra weight and you're concerned about their heart or this, that, the other. We think about phentermine. And so I do think that if you're out there and you have approached your primary care doctor or somebody else in your care team about this and they kind of blew you off like Betsy used to, maybe reapproaching it and saying, look, I've looked into this. There's some new things on the market. If you're not comfortable with prescribing this, is there somebody else you can recommend or look for a bariatrician, anything like that would know more about these kinds of things? Because, also primary care doctors are knowledgeable in many, many subjects. They can't be super deep knowledgeable in every single one.
I know. That's the thing. And I'm actually going to put on a continuing medical education event here in the near future, which is for really mainly for non-bariatric surgeon type providers, like the primary cares or the people who, let's face it, I think we all get into healthcare, into medicine, into nutritional therapy, into all of this stuff to help people. And then when you have this epidemic, this real issue here with obesity, and you, like you said, you have this whole list of other things that they're treating, like, all right, well, today you'll see the signs on the wall, like pick one thing and focus on it. What's your chief complaint, your number one issue that you want to address today? And it's like, well, I don't know. And then we go down the whole thing of like, my knee hurts. Well, that's because you're overweight. Okay, will you help me with that? Eat less and move more. Okay, that's not helpful. So if you've been in that frustrating experience, you're not alone. Unfortunately, that's it. But like Hannah said, just like with surgery that had a really bad rap, these medications, man, oh my gosh, there is some extraordinarily promising medications out there. And I'm just excited to share all of that with you guys. So we're going to start off and we're going to talk a little bit about, all right, you finally made up your mind. Either you've already had surgery, you want to do this, or again, you're just somebody that wants to go on a medication and you're bravely kind of embarking on this journey because it is a journey. Mm-hmm. And, I just want to talk first a little bit about the emotional side of deciding that, oh gosh, just like with surgery, great. My weight has now gotten to the point where I need help. And taking that first step is just super challenging. And it's this conversation with yourself of, all right, let me try to find somebody. And that's the thing that kills me about like sometimes the primary cares or the gynecologist, like, okay, they brought up my weight and now I'm like, okay, what can I do? And then they don't help. And it's just so devastating.
It is. And I think when, it shouldn't be shameful when you need to ask for help. And that is just something. It's always going to come back to society, but like society has always made it more challenging, especially Western society. Like asking for help is really challenging. And then also when you basically have been gaslit all these years of people just telling you to work out more and eat less, and like dietitians are not blameless in that either. I think that's, we focus primarily in that space. And but it doesn't work for everybody. And it's just reality when we look at diet and exercise are just they are a small piece of that whole pie that is a human. And when we look at weight especially, we look at environmental factors, stress, sleep, genetics, hormones, and then diet and exercise are also in that big thing.
Yeah, all of those things. And that's why when you're ready to get the help, I want to make sure that you can get it. And on episode 4, of this 4-part series, we're going to be talking a lot about how do we get these meds covered. Because that's the biggest thing. It's like, okay, I qualify. I'm a perfect candidate. I found a physician or a provider that is actually going to prescribe these meds. And then poof, that'll be $1,600 a month. A month. Oh my gosh. So, all right. So how do we decide what medication is best for you? So it comes down to this evaluation. And that is a typical history and physical. And I think that I'm going to tell you guys some things that might blow your mind. This is absolutely going to be an episode guide. I'm going to start off with your other medical history first and talking a little bit about some of the medications that you might take. So I'm going to tell you about a list of meds, and I'm going to tell you things that might be upsetting. Okay, so I'm going to tell you guys seriously that you might be like, why didn't anybody ever tell me about what I'm about to say to you guys? Because it's something that you are prescribed a medication and the person that prescribed it maybe didn't know or didn't consider that some of the medications have a significant side effect of weight gain. Mm-hmm. And sometimes you've been on these meds, and some of these medications, you absolutely need to treat that condition. But I'm going to provide you with a huge list of medications in that class that cause the weight gain. And if possible, take this list to your provider. I mean, I'm fine with it. Have this discussion and, really just be educated on these things for yourself. Like, be your own advocate. That's what we always propose here as well. But I'm also going to tell you some in that class that treat these conditions that are alternative to that are either weight neutral, okay, you won't gain or lose, which is fine, or even some of them that will help you to lose weight and help treat the condition.
Right. And I think that's the thing. It's not, you always want to make sure you have that alternative in place. Like you said, these, I know we're going to talk about, it's like depression and things like that. Like, we want you to treat those things. Absolutely.
Oh, yes.
But yeah, maybe there's an alternative that doesn't also cause the secondary side effect of weight gain.
Exactly. I think there's so many patients, when I ask them, again, back to like, when do you think you started to gain weight? A classic one is when I took the Depo-Provera birth control injection, for example. And it was like, whoa. Or we're going to start off here with another class, depression treatment, like you said. Mm-hmm. So mental health, getting treatment. Some of you are on the cocktail of medications or just one medication that, like, man, I am from a mental health standpoint, things are great. And if you don't have your mind right, like all this other stuff, like, I don't know, it all plays together. Like sometimes your weight makes you depressed and that whole thing as well.
Right.
But so looking at this list here, so these are the medications that are used to treat depression that do cause some weight gain. So here we go. So number 1 is paroxetine, which is Paxil. Number 2, amitriptyline. And that's a really common one. This is it's like a tricyclic antidepressant, and that does cause weight gain. Also, there are MAOIs. So those medications, they do have a lot of like interactions with other meds, but one is like Pamelor, a lot of weight gain, Remeron, Effexor, Cymbalta, and Marplan is also an MAOI. But Cymbalta, I want to talk about that one for one moment.
That's the one with the sad little blue guy, I think, on the commercials.
I don't know. They haven't targeted me in their marketing campaigns. I don't have to look that up.
Ago.
Well, I'll tell you, Cymbalta is extremely popular because it also, in addition to being used as an antidepressant, it is the only medication found to be effective in clinical trials in treating fibromyalgia. Oh. So one of the only ones. I mean, it's the main one. If a patient has fibromyalgia, typically they're like, I can't live without my Cymbalta.
Right.
And I'm not telling you to get off of that, but unfortunately, that is one that might have caused you to gain some weight. And I think that fibromyalgia can also cause some like focal joint issues. And then if you gain weight because you're on the treatment and now you're heavier, I think sometimes it's like this vicious cycle. And it's like, oh man, like some of you might be like dumbfounded right now, like no one told me that again. And this is like frustrating because it's like this, you're like going in the wrong direction.
Feedback loop.
A negative feedback loop of just hell on some of this and not good. Now, here's the alternatives if you can do them. So some that actually are weight neutral include Prozac, fluoxetine, very popular one, Zoloft, Celexa, Lexapro, and those ones are weight neutral. And guess what? There is one medication that actually causes weight loss, and that is bupropion or Wellbutrin.
Okay.
Now, Wellbutrin is also commonly used to help to curb addictions like nicotine addiction.
Okay.
So that'll be used. And then bupropion, Wellbutrin, is part of a medication, the generic, is part of Contrave, which we're going to talk about on our pill episode, which is on part 2. So Wellbutrin is the best one on that regard for that. All right, now we're going to move on to the diabetes medications for type 2. So one thing, and I'm sure you can speak to this really well, having some of your diabetes education background and all that sort of thing, is there's the difference between type 1 diabetes and type 2 diabetes.
Yeah. So type 1 diabetes is a condition where you don't produce insulin. And you need insulin, like it's required to live. Otherwise, your blood sugar can't enter your cells. It would stay in your bloodstream. You would like starve essentially because your cells aren't being fed. It's generally more common or more commonly diagnosed in younger people. In adolescence is when you'll find it. You'll find 5, 6, 7-year-olds that are diagnosed with type 1 diabetes. It can be diagnosed later on. I knew somebody that was like 19 or 20 when she was diagnosed. And I don't know if I think it's a little bit like late onset type 1 diabetes kind of thing. And so that requires insulin injections. And what happens with it when that happens, and this is why you see weight changes in people, you'll see people drop a lot of weight. And that's a lot of times the first indication of either type of diabetes is just like a significant weight loss because, again, those cells are not being fed the sugar that you're getting in your body, and so you lose weight. So you correct that, and it fixes it. So people will regain weight, which a lot of times in type 1 is not generally as bad because a lot of times they've gotten to be very small or they're kids, and we don't want them to be losing. You don't want kids generally to lose weight.
Right.
On a general kind of consensus. But so then type 2, which used to be considered later onset, but it's become earlier and earlier and earlier now. We are starting to see teenagers and kids even getting type 2 diabetes, but still generally speaking, more older people get type 2. It's when your insulin is you're resistant to that insulin. It just doesn't work as well, or you're not producing enough of it. And so then you can get on some type 2 diabetics will require insulin injections, but a lot of them do like oral medications, like metformin or something like that to treat that. And it's something that we see it reversed with surgery.
Oh gosh, yeah. Yeah, the type 2 diabetes and insulin resistance.
And type 1 though is like not reversible. There are some this is an aside, there are some very cool advancements in type 1 diabetes management where there's like essentially an external pancreas that people can use. It's like such a tight controlled blood sugar monitor and pump system that it pumps in the insulin, and it's like continual glucose monitoring that it's like a game changer. I don't know how available it is. I haven't seen it. I haven't like delved into that in a while, but like,
wow,
it was very cool technology when I last saw it.
Yeah. I mean, there are so many advancements in the treatment, but like you said, type 1, unfortunately, only has insulin. Now, do you have any thoughts on like this new kind of additional category? There's type 1, type 2 we just talked about, and then type 1.5. Where essentially there is it's like a combination of the two, and you don't even almost know what you are because of the way your body's responding.
I don't know much about it, to be honest, so I can't like give an opinion on it. I haven't like read or anything, but it's interesting because again, it's kind of like where we're seeing these kids with type 2 or adults with type 1. Maybe it is some third thing truly.
Exactly. And sometimes it's hard to diagnose. And with surgery, type 1 never will go away, like you said. However, it actually will show you that your blood sugar levels will improve some even after a gastric bypass with type 1 diabetes, which is incredible. Now, one of the problems is insulin.
Right.
It causes you to gain so much weight. It's so hard. Talk about that negative feedback loop. I mean, you need it to survive, my poor type 1s. But then it's like the type 2s because as well, like their insulin resistance gets worse. And then they need the pills aren't working. Then there are some injectables, which we'll talk about, are not working. And now all of a sudden I have to go to insulin. The insulin causes me to gain weight. I need more insulin. My hemoglobin A1C, which is a lab value, which essentially summarizes how your blood sugar levels have been over the last 3 months, and my blood sugar level, according to that, let's say your hemoglobin A1C is over 10, and that means that your blood sugar you're walking around with on a daily basis is like 400.
Right.
You can't feel well with that.
Yeah. No, and those are the people that they don't realize how bad they feel until they feel better too.
I know.
'Cause you're just walking around at that baseline, or that they come in and they're like, "Oh, my blood sugar is 120. I feel terrible."
Yeah.
Because that to them feels low.
So low.
You know?
I know.
And just, a normal blood sugar is 70 to 90, just to give you a reference. Like 120 would be like a higher.
Yeah,
for
exactly.
For somebody who's not diabetic.
So yeah, after surgery, I mean, that's part of the thing that you do in terms of diet and recommendations and carbs and slowly kind of re-advancing. We talked a lot about ketosis on this podcast. There's a lot of considerations. And so it's not just the insulin that causes weight gain. There's some other medications like sulfonylureas, glipizones, glitinides. Now the alternatives is actually what this whole kind of like medical weight loss kind of like blow up is all about right now is first off, this one's not really that great, but it is one that does give some very, very tiny amounts of weight loss, which is metformin.
Right.
Now, metformin is a medication that a lot of women who are trying to get pregnant will be put on because they have PCOS and insulin resistance. The metformin will hopefully help them to lose some weight if they need it and put them on that. Metformin is one that I feel like, I mean, I was put on it for my infertility stuff. I had a little bit of degree of PCOS and I could not tolerate it.
Yeah.
I could not.
What were like the side effects of it for you?
So nauseous.
Okay.
So nauseous. GI. Just so much nausea. I never vomited on metformin, but I was so nauseous. I honestly was like, I can't handle it.
Yeah.
And at the fertility clinic, they're like, girl, when you get pregnant, you're going to have a heck of a time with probably the morning sickness and all that, which I did. But I was just like, I couldn't stand even the metformin.
Yeah. But you're like, at least if I have morning sickness, it's because I have I'm growing a human. There's a good reason for it.
Yeah. I'll just charge on. But I just couldn't do it. So all of you out there, and sometimes, the starting dose is about 500 milligrams and then maybe 500 twice a day and then up to like 2 grams or 2,000 milligrams I've seen. And those people who can tolerate that, I'm like, rock on, man. Like that's a lot. Yeah. That's really tough. And you might have to titrate up or go slowly. And we'll talk about that too.
And you have to titrate down off of it is my understanding. Like it's not something you can necessarily just stop.
Exactly. And just like another medication that we'll talk about here in a moment, beta blockers, which is a high blood pressure medication, also used to help with pulse rate control, might be used in atrial fibrillation. It might be used for anxiety, actually, stage fright. Sometimes you'll use propranolol, which is a beta blocker. Those ones, please listen to this. You cannot just stop those because you'll have a refractory increase, like a bounce back in your heart rate where you'll get very high heart rate, tachycardia, and you could have significant racing of your heart. You cannot just stop your beta blocker. You have to ease off of it.
Ease off your beta blocker.
Ease off of it, my friends.
After talking to your doctor.
Yes, talk to your doctors. Talk to your doctors always. So don't just stop it. Don't play, doctor
and don't just
out there.
stop any medicine.
Yeah,
I would say. Please talk to somebody before you do it.
Yeah, I think this is all very, really sound advice that we're giving out here today. All right, now the other ones, again, we're doing a whole podcast episode on the GLP-1 agonists, so I won't talk too much on those like Saxenda, Ozempic, Victoza, Trulicity. Those are just some of the ones that are useful in treating type 2 diabetes. And then there's a few other ones like these SGLT2 inhibitors, and we'll talk a little bit about those coming up as well. Now, the high blood pressure treatment. Now, the beta blockers I just talked about, so they end in OLOL. So if you're like, I don't know this classification, like what's a sulfonylurea? Like, I don't know. Is the medication I take, is that in that or is that this? Just Google it and it'll tell you. But the beta blockers are typically like propranolol, atenolol, metoprolol, Lopressor, Toprol XL. Those ones, unfortunately, have a little bit of a modest weight gain associated with them.
What when you say modest weight gain, what do you know, like have a number?
It's a low percentage. I'm going to say that normally people will gain like 5 to 10 pounds. So I would assume it would be like 1 to 2%. Okay. It wouldn't be, I don't think it's very much, but there definitely is some. Now, if you have to be on a beta blocker, because like I said, they have a lot of different reasons, not just blood pressure control, but on all the heart rate control. The best ones that are more weight neutral are carvedilol, or it's Nebval. I haven't never seen that one, but carvedilol is a popular one. Yeah. So if you can do it, great. And then there's like ACE inhibitors, which are good, angiotensin receptors, calcium channel blockers, all that kind of stuff. All right. Now, if you're on a psych med, such as like Zyprexa, Seroquel, Risperdal, lithium, there's not really great alternatives to those ones, which is really hard. I know. Yeah. The most weight neutral is like Haldol. That one's pretty good. Zyprex is decent. And some other mood stabilizers, which are pretty weight neutral, are like Tegretol, Lamictal. is one that I've commonly seen. So take these to your psychiatrist. And I'm sure that those, because they know about that significant weight gain, your psychiatrist or your prescribing doctor should have addressed that with you, or at least talked about that as much as they can.
And don't forget, you guys, this will all be in chart form. So
yeah, I know.
I'm like all these names and all these like.
Thanks for keeping breaking it light. We were getting a little too heavy there.
You know what?
It's getting boring for a second, wasn't it?
No, we just are nerds.
Okay, good. I'm like, oh my God, guys, you got your LOL class.
Idea.
You know what? I love pharmacology. I love it.
It's really interesting. Like we're sitting, as we always are, sitting across from each other, and you're just like lighting up about like all of these medications. And I was like, I have heard of that one. Like I remember carvedilol.
Oh my God. I mean, I'm using my hands. I'm just trying not to hit the mic, because then poor Hannah, who edits this, will have to delete out, then edit out that boom sound. So I'm just really trying to stay on here. Now, some of you have a seizure disorder, epilepsy, and there are, unfortunately, some meds that cause weight gain. Now, some of these meds are also used for things outside of seizure disorders. For example, gabapentin, Neurontin.
It's for
you got this.
Pain. Right?
You got it?
In your finger?
A little bit more. Give me more. More specific. Neuropathy. Yes, exactly. The numbness and tingling. Neurontin is used to treat that. It's usually used for our diabetics. So it's like, oh, great, I'm on insulin and Neurontin to try to help with this diabetic neuropathy, this numbness and tingling. And it can also cause more weight gain, more insulin. The whole cycle keeps going. Lyrica is another one. And that's pregabalin is another name for it, and that can cause some. Tegretol is another common one. The alternatives, actually, some of them are great for weight loss, but some of them aren't useful for the neuropathy and things. For example, Topamax, topiramate. Mm-hmm. When you combine phentermine plus topiramate, which also topiramate is used for migraines. You might have heard it for that, Topamax. If you combine those things, the medication, the brand name is called Qsymia, and that medication is one that causes a pill form that causes weight loss, big-time weight loss. And then you got your weight neutral. We talked about the Lamictal already as part of some of the psych meds, the mood stabilizers, the Keppra, the Dilantin. So there are alternatives to that sort of thing. All right, let's talk about one of the biggest myths out there, and I already kind of spilled it a little bit, but it's about birth control.
Oh, yeah.
So people ask all the time, and they say, and I just want your anecdotal thoughts on it, just sort of your perspective on what do you think about birth control by mouth and what it does for weight? What's your gut tell you about that?
My gut? Well, it's so interesting because I don't honestly know a person my age that has not been on oral birth control of some sort throughout our 20s and 30s. To me, I understand where it's messing with your hormones. We know that hormones and women and fat deposition and all of that is so interplayed. But then you get told all the time by gynecologists, no, it doesn't. Or again, like you said, modest weight gain, 1 to 2 pounds. Some people, it really curbs hunger. So there's different things. Some people it causes a huge appetite. I've always felt fairly neutral on birth control.
Yeah.
From that perspective, it didn't cause me to have mood swings or my PMS wasn't bad or anything. And then I got an IUD. That I am convinced has caused it for me personally to be more difficult to lose weight.
Yeah.
I don't know that it necessarily caused me to gain weight, but I think it's made it more challenging to shed pounds.
I think it does. I do. I really do. And I think that just like we talked about, different people's reaction or success rate with medications has to do with sort of their workup. I think to say that the studies show that when you look at the average of all the people, the dead center mean here, the median is saying that there's no clinically significant weight gain, I think is wrong. I think there's people undeniably over and over again I hear that are on birth control. The IUD thing, mm-hmm. I mean, I have an IUD and I don't think for me it does, but I have a best friend who I see every day in the operating room and we would eat the same thing and her weight all of a sudden was it just went up.
Yeah, I said this on another episode, a friend of mine, the same thing, no changes in diet, no change in activity level, got the copper IUD and it was 15 or 20 pounds. And she was a petite woman. Like it was, pretty significant amount. And then she just couldn't. She was like, I'm exercising more. I'm eating differently. Like couldn't lose the weight. Got it taken out and like just fell off.
Yeah.
So, but they're very good for not.
I know.
For
you don't have to think about
birth
things.
control. Like period control.
I know. And even after surgery, if you were to like tell me, hey, which is the best one for me? I mean, I think that you can still take pills by mouth, and I think that there's really no major impact on absorption of them. So I still think that they would be as effective, but there's still a little bit of that. The best one afterwards is probably the IUD,
right? Because it's that permanent.
I
know. Your gut isn't a factor in it.
Totally. I think that one is fantastic.
And it's so easy.
So easy.
They just extended the life of one of them, too. Like, you can keep it for, 7 years instead of 5 because Europe's been doing that.
Oh, thank you, Europe.
Yeah.
That's good. Well, that sounds really good. Now, we talked about this a little bit, but man, the progesterone-only methods. So there's, I think, the mini pill, progestin, and then, of course, Depo-Provera, which is a progesterone-only injection. The perks of it, when you're on only progesterone, it's the withdrawal of progesterone, which gives you your period. Okay. So when you're on, in other words, when your progesterone levels at a steady state are high, that means you're not going to get periods.
Okay.
So when you think about like when you're doing birth control, there's that week of placebo just to kind of keep in the routine of it. But the week of placebo, you're pulling out the progesterone so that you'll have a period. So when you it's like, I'm not going to take the placebo week. I don't want to have a period. I'm just going to keep going straight in. It's that the progesterone has to stay high. And that's also what maintains the pregnancy as well is looking at progesterone. And so when I was on my infertility, I had to give myself this intramuscular injection of progesterone every day. Oh my God, it was awful. But anyway, and it causes you to instantly gain weight. Yeah. Holy moly.
Yeah.
I mean, I was getting in like horse doses amount to keep the pregnancy going. But I mean, the Depo-Provera absolutely causes weight gain, period. Yeah. Period. And the problem is once you get it injected, it's not like, I'll stop that pill tomorrow. It's in that system and it takes a while to wear off.
Right?
Oh no, it's like way longer.
Or that's how often you get them, right? It's like a monthly shot or quarterly?
I think it's like quarterly at least.
I wouldn't want to go to the doctor quarterly.
No way. Stay away from us doctors as much as you can.
I'm obviously very clearly lazy with my birth control.
Oh my gosh.
Like, give me the thing I don't have to think about. I still wake up though at night. I'll go to bed. And I'll be like getting ready to fall asleep and I'll like suddenly wake up and be like, I have to take my pill.
Oh God.
Like, I haven't taken a pill in like 4 years.
Oh God.
What is this?
I think it's PTSD from it.
Yeah.
Gosh.
This is training.
It is trained in you. Right now, I'm in the middle of the holiday season, as we know. And for me, it's waking up like, did I move the elf on the shelf? That's where I'm at right now with my life. I'm like, oh shoot, did the elf move? I hope my little kids aren't listening to this.
I hope your little kids aren't listening to this for a lot of reasons.
Yeah, for a lot.
Because they are.
How about that sex episode we just launched last week? I hope you guys liked it. We're loving the feedback so far. Yes, there it is. There's that. Oh. Now, moving on to, boy, we could talk for hours on this, and we are not. This is why I said 4 episodes. I mean, I'm almost like, gosh, we should have done even more. Okay, so let me pull it together here. We'll wrap this one up. So, inflammation treatment. So, if you have arthritis, if you have pretty much any condition, sometimes you might be prescribed steroids. Corticosteroids, the Medrol dose packs, all of that. You feel amazing. You feel like you could like climb a mountain. Your joints are feeling good. But oh boy.
Just wait.
Just wait. You're going to get the weight gain. So if you're on steroids, if you have like an autoimmune condition where you're like, the only thing when I get these flares is I have to go on a steroid thing, it's like, just not good.
Yeah.
It's really, really tough. And that's another thing just about if you do have to go on a steroid, like these Medrol dose packs, if you've had the gastric bypass, that's the only real medication that we really want you to be on, something to protect the lining of the stomach so that you don't get the gastritis, the inflammation, and ultimately potentially that ulcer. So remember, if you're on that, do something like a proton pump inhibitor like Protonix or like Pepcid, or maybe you need something like Carafate, which again coats the lining, which lets that whole thing heal. Alternatives are anti-inflammatory meds. A lot of our patients are worried about like the Motrin, the ibuprofen, but if you need to take that, it's okay. Here and there is totally fine. If you're on a more regular basis, again, you want to add that anti-reflux medication as well.
And I think a lot of this, too, goes to when we talk about these medications and alternatives. And for some of these disorders, it's also like this could be an impetus for you to try to get to some of the underlying causes of these. Is it from some other, like these autoimmune disorders? Could it be potentially like food related, or could it be, is there some other thing when you're having flares? Are you noticing cycles of when you're having them or things like that? So it's just kind of being your own advocate of saying, I want to take maybe the steroids less often if I can. Is there something we can do to get to more of a root cause of this versus treating a flare?
Totally. And some people on steroids so much they become diabetics. Mm-hmm. And this also plays with the whole cortisol response. And so when you listed off all these multifactorials that go into why people are struggling with their weight, one of the big ones is cortisol levels, and it has to do with your circadian rhythm and sleep, which we'll have a whole episode on that, I'm sure. And the other thing is about stress. Mm-hmm. And when we're stressed to the max, some of us respond by packing it on, that central distribution and all of that pattern. Your adrenal glands are on overdrive. So many things going on there. All right. If you have HIV, obviously, you need to be on an antiretroviral, protease inhibitors. They cause weight gain.
Yeah.
So I know that's sort of always been weird. I've done a lot of patients with HIV, mm-hmm. and I'm proud to take care of them. Like no big deal at all. So if you have HIV, that is not a contraindication to having surgery. I'll still operate on you, absolutely. And I think that a lot of people have the misconception, like, how do I have HIV and I'm struggling with my weight? Like you think of more of the AIDS, the full blown and that cachectic look, but the meds are phenomenal, obviously, but they do cause weight gain.
Right. It's almost because it's that undetectable HIV. It's not that same. Yeah. If we look back in the 90s and when that was kind of that thought of that very, very malnourished person.
Exactly.
Because you're treating the disease, which is great.
Exactly. And that also goes with, back to the whole steroid thing, we talk a lot about transplants. And mm-hmm. I see a lot of post-op and actually pre-op patients who need to get on the transplant list. They need to lose weight in order to be listed for a heart, for a lung, for a liver, for a kidney, mm-hmm. for a pancreas. And they have to lose weight. But some of them have had the surgeries. And then if they're going through like a potential rejection episode or something where things aren't going right, we put them on huge doses of steroids, and then you gain weight. And then it's just this, again, it's just really tough. All right, these last two are going to be the ones that are going to be like the biggest doozies, I think. So the sleep thing, we talked a lot about sleep being so essential mm-hmm. to weight loss. But Ambien, which, oh boy, that can cause you to really have some issues and side effects. One of them is weight gain. Mm. But the alternative is melatonin, which is on the sleep episode, we'll talk a lot about that being a more natural alternative to it. And then finally, this is the last one that it's like, oh boy, allergy meds, antihistamines. Okay, are you ready? Weight gain are things like Zyrtec, Allegra, Doxepin, and then the alternative is loratadine, which is Clarinex.
Okay.
So you want to be on that one. It has the lowest potential for weight gain. Mm. So you want to make sure. Let me make sure. Is that correct? Is loratadine Clarinex? I don't want to tell our fans wrong here. Let me just make sure I look that up really quick. Do you have allergies?
I don't, but my husband does. And he takes the children's, like, I think the Zyrtec.
Okay.
The I don't know, store brand one. And it's like grape flavored.
So it's not Clarinex, it's Claritin.
Claritin.
I knew that didn't sound right. So if you have allergies, my friends, try the Claritin, the loratadine, instead of the other ones.
See, what's sad, what's annoying is like I think that's what he was on before, and then
it doesn't work.
It doesn't work. This one that he's on right now, it's like his allergies are like. Wait, actually, shout out to Debbie for that recommendation.
Oh, yes.
That's who I got that.
She's our numero uno fan. So there we go. Well, lots of these meds, ones that cause weight gain, ones that are weight neutral, and then those wonderful ones, if it helps your condition, and it helps a little weight loss. I mean, what a win-win on those.
Yes. And again, this will all be outlined in a guide. We're going to make it nice and easy for you to check out. So don't fret if you're like, what was that one that they said? I mean, you can listen to this 40 times if you want to, but keep an eye out for those guides. Check us out on drxdietitian.com. Sign up for those episode guides. All of that will be there. We'll also have, I'm sure, some beautiful diagrams and things coming out. Look for us on Instagram at drxdietitian. Any final words on this part 1 of our 4-part series here?
We'll just keep listening, and we love your listening. Boy, I'll tell you, like in November, and our podcast is really just taking off, and it's just so exciting. So we want to thank you guys for listening, for following us on Instagram. That's at Dr. X Dietitian with a T. And make sure you follow us or subscribe to our YouTube. And soon we'll be having even more things. So lots of exciting stuff for us. So I hope you're enjoying this 4-part series on medical weight loss.
Awesome. We'll see you next week.
Bye, guys.